Hello everyone. Today we'll study a short but very important topic, an interesting one, that is intussusception. What is intussusception? It is a condition in which a part of intestine gets invaginated into its own lumen. That is, for example, the proximal part of intestine will get invaginated into its own distal part. And since intestine is getting invaginated into itself, so this is also known as bowel within bowel. You can clearly see here the proximal part of intestine is getting invaginated into distal part of intestine, and this situation is intussusception. Now we need to focus on two terminologies which are important from exam point of view, that is intussusceptum and intussussapiens. So what is intussusceptum? See, this is the wall of intestine which is getting invaginated into the lumen of distal part of intestine. So the border which is invaginated inside, this border is known as intussusceptum. That is name for the loop which is invaginated. And the border which is present outside, this is intussussapiens. Later on, when we will study the clinical features or presentations of intussusception, then we will see that what is the difference between intussusceptum and intussussapiens. Before understanding what are the etiological causes which can lead to this condition, I would like to explain the pathogenesis so that it will be more easier to relate that etiological agents with this condition. So here basically the concept is, if any foreign body is present inside the intestinal lumen, that will lead to this intussusceptum. But not every foreign body can lead to intussusceptum, because as you all know, inside intestine the fecal matter is itself considered as an foreign body, and since fecal matter is present almost at any point of time in the intestine and in every individual, but not everyone is related to this condition. So what is the difference between this foreign body and the foreign bodies which can cause intussusceptum? That is the relation of this foreign body with the wall of intestine. See, if anything is present inside the lumen of intestine, so as you all know, intestine poses peristalsis movement. These peristalsis movement, what they do, they will push the fecal matter or any foreign body inside the lumen to the distal parts, ultimately pushing it out through anal opening. So the role of peristalsis movement is to take anything which is present in the intestinal lumen from the proximal part of intestine to the distal part, ultimately pushing that thing out of the anal canal. So what will happen here? Similarly, any foreign body present in the lumen, but specifically the condition is it should be attached to the intestinal wall. So if this foreign body is attached to the intestinal wall, intestine will try and push this body, foreign body, towards anal opening or in the distal part. So it will perform vigorous peristalsis movement so that this body can move distally. What happens here? Since this body is attached to the wall of intestine, so along with this body, the wall of intestine is also dragged distally. So, for example, here was a foreign body. It will be more clear in this figure, since here is a foreign body that is trapped or attached within the wall of intestine. So when this foreign body is faced by peristalsis movement, along with this foreign body, the wall of intestine will also get dragged inside or towards distal part. So this will lead to intussusception. So what I have written here is, any foreign body attached with the intestinal wall, this is important, in the lumen, intestine tries to push it distally, similar to feces, through strong peristalsis. Along with the foreign body, wall of intestine is also dragged distally, since the intestine don't know that this foreign body is attached to the wall or not. And the point of attachment of this foreign body with the wall of intestine is known as lead point. Now let us understand what is lead point. This point is known as lead point. It is known as lead point because it is leading the invagination of the intestinal wall. Because since this is the point where the peristalsis movement will act, so this is the point which will move first and then will drag the intestinal wall which is behind it. Now these different etiological agents are considered as lead point because, for example, this blue dot represent etiological agent and they may be of varying nature. So these will bind to the wall of intestine and will act as a lead point. Now, what are the etiological agents? I have written few of them here, and then we will see any more on the next slide. First is adenoma. Any kind of adenoma in the intestinal wall will act as a lead point, can lead into intussusception. Then polyps. These polyps are more common in old age in the colon. Then ectopic tissue of Meckel's. I have already explained Meckel's diverticulum in previous videos. And then moving on to the most common cause of intussusception, that is Peyer's patches hypertrophy. Now briefly I will explain what are Peyer's patches. Peyer's patches are present in the submucosa. Since you all know intestine is lined by 4 layers, the innermost is mucosa, followed by submucosa, followed by muscularis, and the outermost is serosa or adventitia. So in between mucosa and submucosa, there is lymphoid tissue which resembles lymph nodes in their functioning, but they are not lymph nodes. Specifically, they are given a name known as Peyer's patches. So that are lymphoid follicles in the intestinal wall, well in between submucosa and mucosa. So what will happen if these are stimulated? This will undergo hypertrophy, leading into this. For example, here were some lymphoid tissue, but when they are excessively stimulated, they will undergo hypertrophy, and this will lead into formation of a lead point. Then that will lead to intussusception. Now let us see what else can be etiological agents for this condition. For a child in age group 6 months to 1 year, the most common cause of intussusception can be weaning. So what is weaning? Weaning is a process of gradual transition of baby's diet from breast milk to some other kind of food that may be solid or liquid. So as you all know that baby feeds on breast milk for initial 6 months after birth, but after 6 months this diet of baby is gradually changed into some kind of solid or liquid diet. So the mother's milk was 100% sterile, but since now baby is getting food from outside, maybe in form of solid or liquid, that is not 100% sterile. And if it's not sterile, so when the food will move into the intestine, specifically into the ileum part, which is the terminal part of the small intestine, then there are Peyer's patches. Usually Peyer's patches is found in whole small intestine, but their maximum concentration is present in the terminal ileum part. So when these terminal ileum part Peyer's patches will face any kind of contamination in the food, they will take it as some kind of infection, and since they are lymphoid tissue, so their function is to fight against it, so they will undergo hypertrophy, and then this condition can lead to intussusception in a child within this age group. Then the other most common cause within less than 2 years of age is Peyer's patches. So they are in a way related, but in question, whatever the option and whatever the condition is given, according to that we will choose our answer. Then other etiological agents can be rotavirus vaccine, adenovirus type 3 infection, polyps. Now this is important since this was the most common cause of intussusception in this age group, and this was most common cause of intussusception in this age group. But polyps are the most common cause of intussusception in old age, because in old age colon polyps are very common. So due to formation of polyps in the colon, that will act as a lead point, and that can lead to intussusception. Other factors: adenoma, ectopic tissue of Meckel's, hematoma of HSP, and some idiopathic causes. These can lead to intussusception. I have already discussed how these etiological agents will cause invagination of intestine within intestine. Then moving on to the types of intussusception. The first one is ilioileal. The name itself indicates that it is the invagination of ileum inside ileum only. This is not so common, but can be seen in few cases where this is, for example, a proximal part of ileum that is invaginated into its distal part, known as ilioileal intussusception. Now one thing you will notice that ileum is very common in cases of intussusception, and that is because I have already just now explained that ileum has the maximum concentration of Peyer's patches. Therefore maximum chances of developing lead point is ileum, because as you all know, the most common cause of intussusception is Peyer's patches hypertrophy, and since Peyer's patches are maximum in concentration in the ileum part, specifically in the distal part of the ileum, so that ileum will act as a lead point. So either ileum is within ileum or ileum is within colon. Moving on to the next type, which is ileocolic. This is the most common case of intussusception found in around 70 to 80% cases of intussusception. Here the distal part, since have maximum pair patches, this distal part will invaginate into the colon. Now here are some interesting facts that sometimes, depending on the nature of peristaltic movement, along with this ileum, the cecum may also get invaginated into its distal parts, and there is no limit or there is no end that where this intussusception or invagination will stop, because since the body or the intestine will try to push the foreign particle out of the intestine through anal opening, so sometimes, very rarely, but sometimes the invagination can reach up to anal opening. But in most of cases, usually in ileocolic intussusception, the invagination will move inside and will stop somewhere in the transverse colon. But in some cases, since this part is also getting invaginated and moving up to the transverse colon, so along with this, the appendix is also getting invaginated. So some patients might come in the clinic having intussusception, and when you palpate or when you have a CT or ultrasound of the abdomen, you might found nothing in right iliac fossa. That is also indicative of intussusception, where the cecum along with the appendix is already invaginated into the transverse colon. So the right iliac fossa will appear empty. I have written here that sometimes appendix may also get dragged inside and can come out of rectum, but usually stops till transverse colon. And wherever it will stop, it will form a lump. This lump is very important in intussusception because this is an indicative of intussusception when we examine a patient physically, that we will discuss in the investigation part. As of now, you must know that intussusception or invagination may reach up to anal opening, but usually or in most of cases, it will stop in the transverse colon, forming a lump. The other interesting part is, since this was the intestine, for example, this is the proximal part, this is the distal part. Whole intestine is supplied by blood vessels, but the part of intestine which has gotten invaginated, this will also drag the blood vessels inside along with it, and this will lead to compression of these blood vessels somewhere here. So the part of this intestine which is invaginated, that will not have any blood supply because the blood vessel supplying it has got compressed at the point of invagination. So this part, or specifically the part which is close to the lead point, this will not have any blood supply and this will undergo gangrene formation over a period of time. So now here comes the interesting point. Intussusceptum, that is the part which is invaginated, will undergo gangrenes. But the intussuscipiens, which is the covering of the invagination from the outside, this will not undergo gangrene development. You can clearly see this is darker part, which means gangrene formation already has started, and the outer layer, this is healthy because this is constantly supplied by blood vessels. So intussuscipiens won't undergo gangrene formation, but intussusceptum will undergo gangrene formation due to compression of the blood vessels, leading to no blood supply. The third type of intussusception is colocolic. Here also the name indicates that it is the invagination or intussusception of colon within colon. And when we were discussing the etiological agents, I mentioned that in old age, polyps in colon are very common. Therefore, in old age, this is most common case because the polyps in colon will act as a lead point, leading to intussusception of or invagination of that part into the distal colon part. Since colic polyps are most common in old age, therefore colocolic is the most common type of intussusception in old age. This is in transverse colon, as you all can see, and this is in polyp. So this will act as a lead point leading to invagination of the proximal part of the transverse colon into its distal part. Now moving on to the clinical features. Basically the clinical features of the patient will complain of pain, which is colicky. What does it mean? Colicky pain is intermittent and spasmodic pain. That is, it is not a pain which will occur constantly for a longer period of time. It will occur in intervals, and the pain will be like it is of wavy nature. The stool is red currant jelly which resembles a fruit, and constipations, since Due to invaginations, the content of proximal intestine won't move into the distal part normally, and it can lead to constipation, some other intoxication symptoms like vomiting and nausea. Then comes the investigation. In investigation, first we will see what are the physical examinations we can do in a patient of intussusception. First one is Dan sign. Dan sign is empty right iliac fossa. I already described how the right iliac fossa can be seen empty on ultrasound. That is, when the appendix and the cecum are dragged inside the colon, then the right iliac fossa will appear empty. So this is a Dan sign. We can palpate and can feel that if there is any part of intestine in that right iliac fossa or not. The second is sausage shaped or banana shaped lump. Now this is important. In transverse colon, wherever the invagination will stop, it will form a lump, and the lump is sausage shaped. That is this kind of shape, also known as banana shape. And one important part that this sausage shape will always have its concavity towards the umbilicus. That is, you can see this is an umbilicus. Wherever the lump will form, either in the ascending colon or transverse colon or descending colon, but the sausage shape, the concavity will always remain or face towards umbilicus. For example, if the lump stop here, then the concavity is towards umbilicus. Similarly, here is also towards umbilicus. If it stops in the descending colon, then also the concavity is towards umbilicus. And usually, since this stops in the transverse colon, so that part is epigastric region. So sausage shaped or banana shaped lump usually in epigastric area, and the lump concavity is towards umbilicals always. Now comes X-ray. That is not that important, and we don't use X-ray for diagnosis of intussusception. But if it is done, then we can see crescent sign and pseudo kidney sign. What is pseudo kidney sign? That on X-ray, a kidney-like structure. That is, this sausage shape will appear like a kidney. This is also seen in ultrasound. Ultrasound is the investigation of choice for the diagnosis of intussusception. Once we have finished our physical examination, the patient is asked to have an ultrasound of the abdomen, where we can see target sign or donut sign. What is the difference? When multiple dark colored rings are appear, then this is known as target sign. But if only two rings are present instead of multiple rings, then this is donut sign. So in case of intussusception, the rings might be two or multiple, resembling target sign or donut sign. I have shown this in previous videos also, so you can go and check there. And the other ultrasound sign is pseudo kidney sign. Now here you can see this is an ultrasound of the abdomen, and this somewhere in the epigastric region, the concavity towards umbilicus, this is sausage shaped, resembling like a kidney. So it is not kidney, it looks like kidney. So it is named as pseudo kidney sign. On CT, we can see target sign, bowel within bowel. Here you can see somewhere here. This is in part maybe transition between ascending and transverse colon. You can see bowel within bowel. These are not that important. Ultrasound is important from clinical point of view, but somewhere it might be used to frame a question. That's why I am describing all these signs that are seen into intussusception. Also, one sign is yin yang sign. As you all know, this is a Chinese sign. This is somewhere like this. Half part is dark, half is black, half is white. So this is also seen in few cases of intussusception, but that is not important. Then comes barium enema. It is very important from point of view of diagnosis as well as in treatment. So what we do in barium enema, we insert the barium from anal opening, and the barium will move to the proximal parts of intestine, and it will go and stop at the site of intussusception. And due to that stoppage, it will make a sign like claw or cup shape. Here you can see from anal opening we inserted barium. This white color is representing barium. This will move and will stop where the part of intestine has got invaginated or intussusception. So it will not move further, and it will stop here, forming an cup shape or claw shape. This is very important. This finding may be used to frame a clinical scenario of intussusception, where the examiner might give this image and might give some clinical features like pain and current jelly stools, and might ask that what condition can lead to this scenario, that is intussusception. And barium enema, it is not only diagnostic, it is important from therapeutic point of view also, that we will see in the treatment part. In treatment, enema reduction or air reduction, it is the preferred treatment for intussusception, where if the enema or the barium which is introduced from the anal opening, if it is introduced with a sufficient amount of pressure, this pressure will push the invaginated part again into its original position. For example, if this barium is flowing with enough pressure, it will push the invaginated part outward, leading to normalization of the intestine. Instead of barium, we can use air, but it will only be therapeutic, and air can't be used for the diagnostic purpose. So enema reduction or air reduction, this is safe and high success rate, but we should know that this is not indicated, it is contraindicated in patients of peritonitis and intussusceptions gangrenes. So if the patient is already having intussusception gangrenes, or if the patient is suffering from peritonitis as well, then in these cases we won't undergo for enema reduction, we will have to undergo for laparotomy. Laparotomy is manual reduction of intussusception. Here, with the help of these three steps, I would like to describe what laparotomy is in case of intussusception. First, we will squeeze. Squeeze means we won't pull the invaginated part outward. Instead of it, we will squeeze the distal end. For example, this is invaginated into this. So we won't pull this backwards, we will squeeze this part so that it moves backwards. So on squeezing the distal part, we will push out the intussusceptions. Then in second step, once the invaginated parts comes out, we will check for lead point. Then whatever the etiological agent is, whatever is leading to the formation of lead point, we will treat that cause. For example, if it is polyp or it is ectopic mucous tissue, then we will try and treat that so that it won't lead to intussusception again in future. Then in third step, we will check for intussusception gangrenes. This is important because maybe you have pushed it out, you have removed the lead point, but what if that part of intestine is already gangrenized? So it won't undergo its normal function of reabsorption. So in that case, if there are gangrenes, then we have to dissect this portion of intestine and ligate the remaining portion. So checking of intussusception gangrenes is very important, and these were the steps we will follow in the laparotomy of intussusception. Thank you so much. I hope this video was helpful. Stay tuned. See you soon in the next videos.